Welcome to the deep dive. We are starting today with a figure that honestly just stops you in your tracks. Over 60,000 families globally since 1980, 60,000 families plunged into this kind of nightmare where they just don't know if their loved ones are alive or dead. And that specific awful void, that emotional legal vacuum, that's the focus of our deep dive today. And we're drawing directly from some really critical research, stuff that's about to hit the global stage.
Yeah, we're looking at insights from a poster presentation. It's set for the World Congress of Psychiatry in Prague. That's coming up October 4th to the 8th, 2025. The source material itself comes from Dr. Ahmed. He's a consultant forensic psychiatrist with the NHS UK and also clinical lead at Aston Medical School. And his presentation title really says it all: Enforced Disappearances in Mental Health. What mental health professionals need to know. So this isn't just about, general trauma. It's very specific. State violence sustained over time.
Absolutely. And our mission for you, listening in, is really to get beyond just the term and understand the deep psychological reality here, this concept of ambiguous loss. We need to figure out precisely why our standard ways of thinking about mental health care, the models built for, say, clear-cut bereavement or PTSD from a single event, why they just fall short. They're often fundamentally inadequate when you're dealing with this kind of systemic state-sponsored trauma that simply doesn't resolve neatly. This deep dive, hopefully, offers a new way to think about it.
Okay, right. Let's unpack this then. Before we dive deep into the psychology, maybe we need to pin down the crime itself. What exactly is an enforced disappearance? What makes it so, well, psychologically destructive?
Well, the key thing to grasp is the deliberate nature of it. An enforced disappearance isn't accidental. It happens when someone is secretly detained, maybe abducted, basically removed by the state, or by groups acting, with the state's backing or permission. And the absolute core element is the denial. The state denies that detention happened, or it refuses point blank to say where the person is or what's happened to them. Their fate is hidden.
So it's fundamentally different from just a missing person case. This is an active, intentional strategy to make someone vanish, designed to create fear, not just for the person taken, but for everyone left behind.
Precisely. And that distinction is so vital because it leads directly to the legal framing. Internationally, this is recognized as a crime against humanity. The intent, the political goal, is to create this pervasive, lasting insecurity.
And the scale. I mean, you mentioned the numbers earlier. The UN has recorded over 60,000 cases since 1980. That figure alone is just staggering. It's like a whole town wiped off the map, but worse because there's no certainty.
And it's not just historical data. That's crucial, too. The source material points out that in 2025 alone, just 1 year, nearly 700 new cases were reported. Across 41 different countries, this is very much an ongoing global issue.
But here's the really sobering part, the bit that makes even those horrifying numbers feel incomplete. Dr. Ahmed emphasizes these figures are almost certainly a massive underestimate.
Yeah.
And the reason why is baked into the crime itself, isn't it? The trauma comes from the state. So there's this immense fear of reprisals. Families are terrified that if they speak out, if they report it, maybe another family member will disappear.
It forces this impossible choice on them, seeking justice versus just basic survival. Silence becomes a survival mechanism.
Which is just awful.
And what's really interesting, connecting this to the bigger picture, is how the source material suggests this scale, this horror, hasn't always translated into global urgency. Part of the reason, it argues, that this specific crime maybe hasn't received the focused attention it deserves from global bodies is because, statistically speaking, it doesn't hit the Western world with the same frequency or intensity.
Right.
So the result, perhaps inadvertently, is that it gets categorized sometimes as, an issue for over there for developing regions. And that perception can slow down the resources, both mental health and legal, that are desperately needed.
That silence, that sort of geopolitical blind spot, just makes the work being presented in Prague feel even more essential. Because when these families do eventually seek help, maybe years down the line,
What do they often do?
they run up against a mental health system that's often just not set up for what they're going through. And that brings us squarely to this core idea, ambiguous loss.
Yes. And this is the absolute critical distinction professionals need to get their heads around. Disappearance is not the same as death. There's no body, usually no death certificate, no official confirmation. So the person is just perpetually missing. The family's left suspended, trapped in this psychological limbo. They can't fully grieve because there's always that possibility, that flicker of hope, the person might just walk back through the door someday.
Right.
But they can't hold on to that hope completely either. because the absence is real, it's painful, it's every single day.
Society wants closure, the system wants closure, but the state has deliberately made closure impossible.
Exactly that. And this emotional trap, this limbo state, it doesn't exist in isolation. It tangles up completely with the practical, everyday realities of life. It becomes this one continuous grinding source of trauma.
So we're not just talking about the obvious psychological fallout, the complicated grief, PTSD, the depression, the isolation, which must be immense.
Immense, yes. But it goes beyond that. It's the sheer administrative and legal paralysis it causes.
Right, like day-to-day functioning. If you're the spouse or the parent or the child of someone who's disappeared, your legal standing just vanishes too, in a way.
Absolutely. The source really highlights these legal struggles. They're devastating, and they feed right back into the psychological burden. Imagine trying to manage inheritance when the main earner is officially just missing.
How do you even access their bank account to pay the rent or buy food?
Exactly. Or make critical decisions about children's schooling or health care without the other parent's confirmed status. Dr. Ahmed really stresses this point. The psychological pain is inseparable from these ongoing, bureaucratic, legal brick walls that the disappearance itself creates. The trauma is structural, it's systemic, not just locked inside someone's head.
Okay, here's where it gets really interesting then, especially for you, the listener, if you're looking for that direct, actionable framework. Because Dr. Ahmed's work isn't just about describing the problem. It lays out 4 clear, concrete takeaways for clinicians, directives to help shift the care model so it can actually meet the specific, complex trauma.
And these 4 points are, well, potentially quite revolutionary because they push back against a common impulse in Western mental health, which often defaults to looking for individual pathology, what's wrong with the person. The first 2 points are really about shifting that perspective, focusing on context and validation. So the first directive is foundational. Validate the distress. Recognize that the intense, overwhelming reactions families have, the anxiety, the anger, the feeling of being stuck, these are natural responses. They're understandable reactions to a crime against humanity.
Not just symptoms of an illness.
Precisely. They aren't signs of individual weakness or failure. They're signs of having endured the unbearable. So validation is the first ethical step in providing care.
Okay. And the second point builds on that, but it feels even more challenging, maybe. Avoid medicalizing a political problem.
This one is definitely nuanced. It's tough for clinicians trained primarily to diagnose and treat symptoms according to, say, the DSM. If someone presents with clear signs of crippling depression or severe PTSD, the standard medical reflex is to label it, give it a diagnosis, and then treat it, often with medication or standard therapies.
But hang on, isn't there a risk there? If someone is clinically depressed and you sort of avoid calling it that, aren't you potentially withholding necessary treatment? How do you balance that clinical need with the political context?
That's the absolute core tension. And the source material isn't saying don't treat the symptoms or withhold care. It's about the framing of the condition. Dr. Ahmed argues that if we only frame the suffering as, say, PTSD or major depressive disorder, we run an ethical risk. We risk inadvertently shifting the focus and therefore the responsibility away from the state that perpetrated the actual root cause of the trauma and placing it squarely onto the individual victim. It pathologizes their response to injustice.
Ah, I see. It makes the problem internal rather than external.
Exactly. So the care needs to be broader. Yes, provide psychosocial support for the symptoms, but do it within a framework that constantly acknowledges the political reality. It means that support might also involve elements of advocacy, connecting families with legal aid, or truth commissions, things that address the external source of the pain rather than just trying to manage the internal reaction to it. The goal is supporting the person while actively acknowledging and maybe even fighting for external change.
That reframing feels huge. It fundamentally changes the goal of therapy, doesn't it? So if those first 2 points are about validating the experience and its political roots, the final 2 seem to be about redefining what healing or even resolution can look like in this context. The third point is recognize ambiguous loss and reframe closure.
Right, because traditional closure, like having a funeral, marking an ending, getting official confirmation, that's usually impossible here. Clinicians absolutely cannot push families towards moving on in the conventional sense. They have to accept and help the family accept that this kind of loss is nonlinear. It doesn't follow predictable stages.
So if traditional closure is off the table, what does a positive outcome, or let's say reframed closure, actually look like? What are we aiming for?
It's a shift. Instead of aiming to end the grief, which might be impossible without answers, the aim is to help families create meaning within the ambiguity. Closure, in this sense, might come not from finally confirming a death, but from achieving some form of social or political justice. Maybe it's having the state finally acknowledge the disappearance through a truth commission. Maybe it's participating in collective remembrance rituals that honor the disappeared, even without a grave. Healing becomes about reclaiming the narrative, fighting the oblivion the state tried to impose, finding community recognition, and pursuing justice, rather than just quiet emotional processing.
Okay, that makes sense. It's about restoring dignity and acknowledging truth. And the fourth point. This one feels crucial for anyone working in these difficult areas: professional self-care.
Absolutely vital, and often overlooked. Clinicians working with survivors of enforced disappearance are dealing with constant exposure to narratives of state violence, of institutional betrayal, of profound systemic injustice. The risks are high. We're talking about secondary traumatic stress, of course, but also something called moral injury. That's the psychological distress that arises when you're forced to act, or perhaps fail to act, in ways that go against your deeply held moral or ethical beliefs.
Because you keep hitting these walls, these state-imposed barriers that stop you from actually helping your client find the resolution they need.
Exactly. You feel complicit or powerless within a system causing harm. And on top of that, depending on the country or context, clinicians themselves might face risks. Providing this kind of support can be seen as dissent, as resistance. So ensuring their own physical safety and the safety of their organization becomes paramount.
So the responsibility isn't just on the individual clinician to be resilient?
Not at all. Institutions have a major responsibility here. They need to provide robust clinical supervision, peer support, and protective measures for staff working in these incredibly demanding and sensitive areas. Burnout is a huge risk, but so is this deeper moral wounding.
Right. So wrapping this up, what does this all mean for the bigger picture? For us, for anyone working in or thinking about global mental health, it feels like the core message is: we have to truly internalize that enforced disappearance is a political crime, a recognized crime against humanity. And therefore, the mental health response can't just live inside a diagnostic manual. It has to acknowledge the messy, nonlinear, practical, legal, and fundamentally political nature of ambiguous loss.
Precisely. We're treating survivors of a specific crime with ongoing legal and social dimensions, not just patients with a decontextualized illness.
It changes everything.
It does. And this body of work really underscores that idea that knowledge is power. Critical thinking has to guide us, sometimes even override our standard clinical assumptions, when we're faced with suffering on this scale, rooted in political violence. Dr. Ahmed's work, heading to Prague, really offers a concrete starting point for applying these vital principles more widely. He'll be there, keen to connect, keen to share these ideas globally.
Which leaves us, and you, with a final thought to maybe chew on. If the path to healing from this specific trauma, ambiguous loss, requires things like recognition, justice, community validation, not just individual therapy focused on symptoms, then what other kinds of deep-seated trauma might we be misdiagnosing or addressing inadequately right now? Think about the long-term impacts of, say, economic precarity or systemic discrimination or even slow environmental disaster. Are we sometimes focusing too much on individual pathology, on fixing the person, when the real need is for systemic validation, for acknowledging the political or social roots of the suffering? Something to consider. How might these four principles: validation, avoiding medicalization, reframing closure, and ensuring professional support apply in your own field in the challenges you see? Think about it.